Good morning. We're Team 2. We're here to present to you our decision on what to do with the $100,000 grant for improving health delivery services in your state. As is evident behind me, our choice is to go with the Department of Veterans Services option. To paraphrase, that entails finding veterans in the Medicaid applicant pool and transferring them over to VA benefits, which is both beneficial for the veterans themselves and will save the state money. In presenting our decision, we're first going to start with some key assumptions that we made in our analysis, followed by the objectives of both your agency and the project itself. We'll then look at some strengths and opportunities that this option presents us, as well as some challenges that we might face. Lastly, we're going to conclude with a brief comparison of the DVS and DOC options, which we feel justifies our decision. So to start out, some key assumptions. Some apply to both the DVS and DOC options, including that the data samples that we were given were representative across the entire population of veterans or inmates. We also assumed that all facilities were operating not quite at full capacity, so that we had some wiggle room to add new members to these pools, and also that we did our analysis using best case scenarios for both. As for the DOC, we assumed first and foremost that all inmates were eligible for Medicaid. Then we assumed that there would be a 0% growth rate in the inmate population because we have a full state prison with very little turnover. We also assumed that the 75% hospital discount rate would still apply under this proposal. As for DVS, the most important assumption we made was that VA benefits are beneficial and desirable for the veterans. Therefore, no veterans will be enrolled in both Medicaid and VA benefits, even if they are eligible for both. And our last assumption for DVS was that all veterans will reapply each year and remain enrolled in their VA benefits program.
In conducting our analysis, we focused on the strengths, the opportunities, and the challenges in both of the proposals. And throughout that, we wanted to keep in mind your key objectives of, does this streamline business practices? Does this better coordinate among agencies? Does it improve the customer service? And does it maximize public benefit and cost savings to the state? Now, in looking at numbers and trying to quantify cost savings, what we did is we quantified the best case scenario for both of them to be able to compare. And overwhelmingly, we found the DVS was much more beneficial, saving the state potentially initially $170 million compared to $30 million for the DOC. And in a couple more slides, we'll go into a little bit more details on how we quantified that. So much greater significance there. It'll give us more money to invest in other programs. It gives us more flexibility to get a greater public benefit beyond the initial program. And it moves these veterans into better quality services, services that are more in tune with their specific needs. It also reduces the caseload burden for the DCH. The DOC proposal puts more people into the Medicaid system. They have to process more applicants. It burdens the system even more. The DVS process streamlines it and makes it easier. We've already seen similar programs implemented, such as the case in Washington, which have been successful. It's a model that we can work from. We can glean best practices. We can see the challenges that they face and intuitively work those into planning our proposal. And politically feasible. When you're looking at this, you have to think about the political implications. And the public at large may be a little bit concerned, even though with the DOC proposal we're just shifting the burden of tax, of who's paying the tax. It's still coming from the taxpayers. It might open us up to additional media scrutiny, maybe a story, why are taxpayers paying for incarcerated persons, where there's much more public support in supporting our servicemen and women who have sacrificed so much for us.
Now there are two important opportunities that we'd like to touch on. The first is in creating this system, we're able to streamline this process that connects two healthcare agencies and put them together so they can best serve the citizens of this state. Now this information sharing, this builds relationships and it establishes trust so that down the line, there's already this relationship built so that they can better serve the citizens in future projects. Secondly, as we touched on before, this policy will enable better cost savings. And with those extra resources the state now has available, they can choose to invest it in different programs. One of which could be reaching out to the veterans that are eligible for benefits, but will not be found in this system, because this system is simply taking the veterans applying for Medicaid and transferring over to the correct system. There are still 270,000 veterans that are eligible for veterans benefits but aren't receiving them simply because they haven't applied. And we can use those funds down the road to maybe improve the system even more.
And you've heard us talk about the cost savings several times so far, and we just like to let you know where we got those numbers from. Although both proposals would produce cost savings for the state, the DOC savings would total up to $30 million. And that's from the roughly 1,800 inmates each year who are hospitalized for more than one day, which is where the Medicaid part would take over. And that amounts to, even after the 75% discount, that would still amount to $17,000 per year per inmate that the DOC pays out of pocket. So with that, so that's where we got the $30 million that the DOC would no longer have to take care of. In contrast, the DVS proposal, it creates $170 million in savings, and we got that from the roughly 170,000 veterans who are currently enrolled in Medicaid. Of that, 82%, which is 138,000 veterans, are enrolled in Medicaid are eligible for VA benefits, and that costs the state about $1,200 per veteran each year that we could take the burden off the books, so leave the state with $170 million to spend as they see fit. So, and talk about public benefit, that's 138,000 veterans who would be directly affected by this, with potential for reaching out to the rest of the 270,000 who they cannot target yet, as opposed to the 50,000 inmates who would get increased coverage.
Now, we believe that the DVS is the best policy to invest in, but that's not to say there aren't challenges. And it's important to note these challenges as you're considering the two policies. So first, we're transferring the burden. So while we're relieving the caseload on our system, on our department, instead that's transferred over to the VA system. So it's important to note as the state, because the state citizens, the veterans, will be transferred to a system that does have some constraints on it already. There's also a logistical concern. First, veterans are going to be transferred to another system, which means they're going to have to transfer their medical providers. And that could cause some uneasiness for the veterans. Additionally, the VA hospitals are scattered around the U.S. This means that in order to receive the services, there are going to be some veterans that will probably have to travel a farther distance to receive the care that they need. But we believe, in speaking with the DVS, that they're able to provide a vast range of treatments not available to the veterans currently on Medicaid. And so ultimately, this offsets the transportation issue. Additionally, there is a sort of lack of trust in the VA system from the public standpoint. It's lost a little bit of trust in the delivery of services available to veterans. That's important for the state to note, because the state is deciding on which policy, and that will have an impact on the veterans, on their state citizens. But there's an opportunity here. There's an opportunity to build trust back by showing that the state is investing in its veterans to ultimately receive better treatment. Additionally, the VA workforce, who may have lost some morale due to the public backlash, has the potential to grow and to raise morale, which could ultimately lead to the workers taking more pride in their work, decreasing processing times, and ultimately better serving the state citizens, which is our objective here. Additionally, there are some political constraints to consider when transferring from a state to a federal system. The federal system sometimes moves slower, maybe funding may be overshadowed by political considerations, but those same kind of bureaucratic constraints are felt by federal and state governments. So we don't see that as being a reason to rule out this proposal. And finally, as we stated before, there isn't going to be an increase in veterans receiving services. It's simply veterans being transferred into the better services provided. But with the cost-saving measures, there is opportunity to grow this process, to grow this program, and ultimately better serve the veterans and reach out to those 270,000.
So in summary, while analyzing each of the proposals, we weighed them against the objectives that the committee wishes that this project fulfill. So in terms of streamlining business services, we consider that the DOC option is simply a tool to cut costs, while the DVS option gives us an enhanced ability to identify candidates, which is closer to their mission. In terms of agency coordination, we have to acknowledge that both options will make the process of DCH receiving the referrals easier, but only the DVS option gives us meaningful coordination between agencies, namely the identification of eligible candidates and the delivery of services by the appropriate organizations. Finally, in the two bottom lines, we can see that customer service, in terms of customer service, 138,000 veterans will be receiving better benefits. While in the DOC, the inmates aren't going to be receiving better services. The organization is simply trying to shift the costs out of the organization. And in terms of potential cost savings, it's very clear the DVS option is more than five times better than the DOC option. So we strongly recommend that the committee choose the DVS option, and we'd be happy to answer any questions.
Thank you.
Can you put back the slide 9? That's a good summary slide. Could you talk to me about first the business practices, how the DVS option streamlines business practices, how things are going with that?
So the DVS's mission is to identify the eligible candidates and refer them to the appropriate resources. So implementing a tool that multiplies or improves the way in which they do that fulfills their mission better. And in contrast to the DOC option, it's their mission is basically to serve the inmates, but not necessarily refer them or provide them with healthcare services. So I think that being closer to the mission of the organization, the DVS option will benefit most.
As you're aware, 1 in 4 veterans who are eligible for the VA services are not using them. And we attribute at least some of that to asymmetrical information. They're just not aware. And what this does is this proactively identifies people who are aware, who may not realize that they've been aware, and refer it. So in that case, that's doing the effort for them. It's narrowing that gap and it's addressing that problem.
So this is actually an IT system or a data analytics solution because it's identification.
And to add to that, it would also alleviate a lot of the pressure on the side of DCH. The more people that we can get out of their system, it allows them, because they are running at near full capacity at the moment, it's a 3-week processing period, and the more people that we can alleviate for that, it allows them to process more people who would otherwise wait a longer period of time for their Medicaid services who aren't veterans, and it could allow for potentially reduced processing times.
Can you go back to your data analysis slide? Walk me through a little bit how you got these numbers.
Sure. So of the 2.4 million beneficiaries of Medicaid, 7% are veterans, which is where we got, and then of the 900 vets, so we have 168,000 veterans on Medicaid, which is the 7% of, and then 82% was from our sample. It was the amount of veterans who were in the Medicaid pool who were also eligible for VA benefits. So that's where we got the 138,000.
Yeah, I just wanted to add, if you're not done, that the monthly cost for the veterans that are eligible is $205
per month.
per month.
Yes.
So per year, it's about $2,460, and that gives us actually
The total Medicaid.
$340 million. But since the state is paying for half of it right now,
That was the
the savings
170.
are
So this is just state savings alone.
So it's assuming every single person that's a veteran on Medicaid right now
and rolled over to the,
Yeah.
So do you think that's a realistic goal? I mean,
We did best case scenario. That's,
so what
that's,
could the state expect right away for return?
I mean, we know it's not gonna happen immediately. And this is just going from business as usual to optimal case scenario. It might take 8 to 10 years, and it's obviously gonna be staggered, but we're just going from business as usual to best case scenario.
Okay, so it takes 8 to 10 years before we even get to the point to realize this. How quickly would we be able to realize the $30 million savings for the DOC?
In terms of time frame, maybe one of my colleagues can give you an exact answer to that, but I think the reason that we went 100% optimal performance is just to show this is what could happen, and even if it dropped below that, even if DVS operated at a 50%, that's still more savings than at 100% of the DOC, and it's fairly safe to assume that it's not going to be, especially right away, 100%
Also,
performance.
the 30 million, that is potential savings, just because it would enroll the inmates, just because they could file the paperwork easier or get the information over to DCH faster, does not mean that DCH can process all those inmates all at once. It would still take time to be able to process all those. So even though the savings could be realized sooner, it still would not the time frame would not be worth the dollar value that it would produce, just based on the scale alone, because 170 million represents about 5% of the state's burden of Medicare for each year. Even if we got 20% of that, it's still about 1%, which is a pretty large number.
And also you have to consider that the DOC Medicaid coverage will possibly reduce recidivism in the future. So while this cost savings of $30 million might not be immediate, the amount of care that these inmates are getting in jail will possibly be reduced because they can lead to more future benefits for these inmates once they are released. So you have that in conjunction with the current improved awareness of mental health, for example, for veterans who are using services more and more, which would increase the state's burden even greater if these veterans were not on Medicaid as opposed to VA benefits.
And 2 more points too. If you look at the Washington case as a case example, they managed to save $30 million while enrolling significantly less than 1% of our projection here. If it's less than 1% of 138,000 veterans, we know based on the Washington example, we're still going to save more money than the DOC proposal. And secondary, this doesn't include other long-term benefits. Like, this is just based on the people that are in the system now, so we're not accounting for the long-term liabilities that the state has for newly eligible folks that enroll in the system.
Kind of going back to there is some implementation cost here that's not factored into the savings, right? So this, the 170 million, even if we assume that number is correct, it doesn't include any implementation costs from the state, right?
That's true, but we believe that the difference is so great that would be negligible when comparing the two.
And what's your baseline for making that statement?
Well, we're thinking that if you're going to implement the DVS option, you're going to have to hire some people to look through these systems, such as Paris and Washington, identify those veterans, get them enrolled. That will take some manpower, but we're not considering the salaries to be a very big chunk at all of that 170 million that we could possibly save the state.
Explain to me what Paris is, I'm not familiar.
It's a system in the state of Washington, a computer-based system where all Medicaid eligible people are listed. And there was one man who kind of began searching through this for veterans and thinking, hey, some of these people on here that are getting Medicaid could have much better benefits. And he saw that there was a gap, a lack of awareness for these veterans. So we're going to look at these examples and some other uses in other states and use those best practices and hopefully improve upon them in our own.
For explaining.
All right, 20, okay. Thanks a lot, really appreciate it.
Thank
Thank
you.
you.
for your time.
Thanks.